Yes, we can.
Yeah, thank you. So, welcome to the nursing session of the month, June 2026. So, today we are going to step into BMT, bone marrow transplant based session. So, bone marrow transplant, especially in pediatrics, is coming up in a huge way, and there are more and more centers which have started doing this. And it's it has become a must-know topic for any staff who is planning to invest their career in the pediatric hematology oncology. So we will start with the basics. So conditioning chemotherapy is something that we do to eliminate the stem cells from the patient so that they can receive new stem cells. So that is the first step and the basic step that is very, very important in a pediatric or any bone marrow transplant. So to discuss about that and how do we care for a child while they are going through a conditioning during BMT. So we have Dr. Baqi Hussain, who is a consultant from the Department of Pediatric Hematology and Bone Marrow Transplant, along with his team member, Ms. Mamta, who is staff nurse in the same department at Little Star and She Women and Children Hospital from Hyderabad to talk to us about the basics of conditioning and how do we care for those children. So I request all the delegates to please to engage actively in the meeting. Ask questions to the speakers through your text and chat box so that we can take them up at the end and make use of this opportunity. With this intro, I request Dr. Wahid to take over the session and start it. Thank you, Dr. Wahid.
Yeah. At the outset, I would like to thank ma'am and IBPHO chapter for giving me this opportunity. It was wonderful to take over this session and like my exciting part of Hematonc is the BMT in which I'm excited and interested in. So it was very good getting this topic and thank you so very much. So today I'm going to be speaking on conditioning chemotherapy and care of the children during the BMT. And I'm Dr. Wahid. I'm from Hyderabad. I'm practicing in Little Stars and She Hospital as a consultant in the Department of Pediatric Hemato-Oncology and Bone Marrow Transplant. And I'm here joined by my staff. She'll introduce herself.
Good evening, everyone. Myself, Mamata, staff nurse in the Pediatric Hematology Department under Oncology and Bone Marrow Transplantation in Little Star Hospital, working from 3 years.
So I will not waste much time and I'll go to the topic. So today my agenda is to cover all these topics in this session. So today I will talk about what is conditioning, what is the history of conditioning, necessity, rationale behind conditioning, what are the types of conditioning that we know, the TBI, the total body irradiation, as well as the chemotherapeutic agents, and then in the last about the routine care of children in BMT during their conditioning. So what is conditioning? Conditioning is basically the preparative regimen which we administer to the patients which are undergoing bone marrow transplant before we will give them the stem cells. So our aim is to do myeloablation, lymphoablation, as well as attain a lot of immunosuppression during this phase. As you can see in this diagram here, you can see that this is a typical what we do for a haploidentical transplant with some chemotherapy before, some chemotherapy after, and some immunosuppression later. And you can see in the day minus, which are labeled before the transplant, we have used here cyclophosphamide, fludarabine, and TBI. So this is how a typical protocol looks when we do a conditioning where there's a combination of multiple agents. Coming to the history, so it goes back long back to 1940s and 1950s when there was World War, and they had seen that there was some protection of survivors even after accidental high dose exposure to the radiation. So this was actually then attributed to autologous recovery. So from that, the concept the humans got is, yeah, then what if we can transplant bone marrow from one person to another person, and that causes recovery of the bone marrow after irradiation. So first attempt for HSCT was done in France by Thomas, where he did around 5 patients. He infused bone marrow who had received irradiation and or chemotherapy, but there was no sustained engraftment of cells in these patients. So in 1968, we had the first successful human engraftment of allogenic hematopoietic stem cells, and that was in a patient of severe combined immunodeficiency, which is an immunodeficiency disorder. And this emphasized at that time that there was an importance of immunosuppression before we go ahead for bone marrow transplant. So conventionally, they were using regimens just based with TBI because that's what we learned from history about radiation. So we thought radiation was the only thing which we could use. Then we slowly started using even other chemotherapy agents like cyclophosphamide, and then we used other agents apart from cyclophosphamide. And now we have almost moved to an era where we are avoiding TBI and we are using only chemotherapeutic agents to do the conditioning. So what is the necessity of conditioning? See, there are three things model in which the conditioning acts. Basically, you're trying to control the donor immune system, which is going to go and later on attack the host immune cells, in the sense host leukemia cells, that is producing a graft versus leukemia effect. So that is how it causes good recovery of immunological recovery for causing graft versus leukemia effect in a patient with leukemia. Second thing is that you want to go against and overcome the barriers which are to the rejection of the transplant which you're doing. That is the recipient's own innate and adaptive immunity. So that immunosuppression also we have to attain. Along with that third thing which you have to understand is bone marrow is something like a factory. It's like a kitchen. You need to make space over there for the niches. Niche is basically a microenvironment inside the bone marrow which will need opening up so that we can get good, smooth engraftment and sustained engraftment by the donor stem. You know that the hematopoietic stem cells are in a quiescent state, hematopoietic stem cells from time to time as per the requirement. Now, what the conditioning does is that conditioning opens up the hematopoietic stem cell niches. Now, this creating space has actually been explained by two models. That is, one of them is augmentation model. In augmentation model, there are new niches which are being created by the conditioning. Now, the replacement model says that actually it's being replacement of the recipient already existing niches, or the niches which are filled by the leukemia cells have been replaced. So these are the two models, but that has been still been controversial. Now, as we know that one size does not fit all, we need to the conditioning is quite in some physician or treatment preferences in some institutes. So classifying the conditioning regimens, what you need to understand is there are broadly three types after the 2006 meeting of the CIBMTR, where we divided regimens into myeloablative, reduced intensity conditioning, and non-myeloablative. To very easy, simply understand is this graph where you see the minimal pancytopenia, no stem cell support required when we do a non-myeloablative regimen. Whereas for the myeloablative regimen on the other end, it is an irreversible damage and there is a stem cell support required. RIC, that is RIC, falls in between. So like I told about myeloablative conditioning, it eradicates the bone marrow, profound pancytopenia, long lasting and irreversible, and it needs rescue with hematopoietic stem cell infusion. Usually example is what I was using for alkylating agents with or without TBI. Whereas a non-myeloablative causes minimal pancytopenia or minimal cytopenias and does not require hematopoietic stem cell support, like our fludarabine cyclophosphamide ATG or fludarabine cytarabine idotabine or TBI less than 2 grays with fludarabine. Now, this is something which has actually revolutionized the pediatric BMT that is a reduced intensity conditioning. Why? Because we have children with most of the disorders that we do transplant for in children are benign and not malignant as opposed to the adults. So in the non-malignant diseases, we do not necessarily need a cytoreductive conditioning regimen, which is myeloablative. We are okay to go ahead with something which is reduced intensity. And there are patients in our cohort, in the pediatric cohort, who are very fragile and have some poor performance status when we are taking them up for transplant. So for them also this reduced intensity conditioning helps. So the importance about this is that we use the chemotherapy radiation doses decreased by around 30%. So, as per the definition given by CMBMTR expert panel, TBI, if anything, less than 5 grain a single fraction, or overall less than 8 grain fractionated, less than 9 mg per kg of IV or oral equivalent busulfan, less than 140 mg per meter square of melphalan, and less than 10 mg per kg of thiotepa and B, including beam, which we use for Hodgkin's, all come under RIC. So there is a subcategory within the myeloablative called as reduced toxicity, where there is fewer side effects. So this is something which is a small part of it. Now you can see here there are various conditioning regimens which I have enlisted based on the toxicity and intensity. You can see it's starting with TBI in the lower rung of the ladder, and the upper rung of the ladder you have the highly toxic Boo side TBI, and that explains you how toxic and how intense the regimen is going to be. So first, as a part of the entire conditioning, I'm going to be talking about the irradiation, that is the TBI. The total body irradiation is uh, is given with the aim to cause immunosuppression as well as myelosuppression. The very important aspect of giving TBI, especially in cases of leukemia, is that it penetrates the sanctuary sites, which is targeting the testis and the CNS. How does it work? It basically causes single or double strand DNA breaks and causes the cellular membrane damage, apoptosis, and cell death. So TBI in our in our chemotherapy regimens, after the studies which have been proved that TBI based leukemia regimens are better, faring better. That is 12 to 18 grade TBI which we use in fractionated along with chemotherapy agents. And usually this TBI based regimens combine cyclophosphamide, busulfan, melphalan, cytarabine or etoposide. TBI fractionation. So TBI fractionation we do so that we get decreased organ toxicity. And the thing is that normal cells have intact repair mechanisms. Intact repair mechanisms which are retained in the normal tissues, and therefore they will get they will get a time to recover before they get the next hit. So the fractionation helps in preventing the damage to the this one normal cells. So yeah, so coming to the complications, the dose of irradiation. So what we do usually is that we monitor for the side effects during the radiation, in the early onset side effects and the late onset side effects. And what happens is usually during the radiation we see nausea, vomiting, some rashes, erythema, or some burns. Early onset issues like mucositis, alopecia, diarrhea, pneumonitis, and marrow suppression, and late related to hormones or cataracts or puberty, fertility issues, hypothyroidism, short stature, dental complications, and organ complications like kidney, lung, cardiovascular, and bone density issues. So yeah.
Sahid, I think your network is having some issue.
Discussing about radiation therapy. What is the question with the radiation therapy?
So they may require repeated anesthesia because of the repeated fractionation. So that has to be taken care of. And while transporting the baby in and out of the unit for the radiation to the whatever ramp, wherever you're transporting the patient, so that to avoid the concurrent infections. So what we do usually, now that we have finished about radiation, I'll talk about the high dose chemotherapy which we are giving for the combination therapy, why we are using in conditioning and not just single agents. Because with combination steep dose response curve, and at the same time not exceeding maximum tolerated doses by the drugs. So basically this helps in tolerating the treatment at high doses. And also the cell cycle non-specificity is a characteristic of the high dose chemotherapy which we give, and with the wide biological activity and synergistic effects we are able to successfully myeloablate and lymphoablate the patient.
So, yeah, we are giving chemotherapy administration. During chemotherapy administration, we are undergoing with the general routes like chemo chat during administration and rechecking and cross-checking with the medication along with chemo administration. And during chemo administration, we are giving pre-medication to avoid the nausea feeling due to we are giving high dose chemotherapies. For that, we are giving anti like palinosetron with avoid spills.
For this pill management, which I think is a topic for another scenario. So, talking about alkylating agents in chemotherapy, you know that the alkylating agents which we use are bind usually to the DNA molecules, and they are cell cycle non-specific, forming strand crosslinks, and they prevent the DNA synthesis. So, busulfan, triosulfan, thiotepa, melphalan, and cyclophosphamide come in this group. So, I'll talk about each drug, and my nurse counterpart will be telling us about how they take care as a nursing rule when we give each of these drugs. So, coming to busulfan, you know that it is a very myeloablative agent which targets the myeloid lineage cells and also some limited toxicity to mature lymphocytes as well. And it has been widely been used as an alternative agent to TBI, and it's actually these agents are now replacing the TBI in some conditioning regimens. So, you know that pharmacokinetics is important when it comes to busulfan and triosulfan, and these agents are usually available as tablets oral as well as parenteral IV solution. But the problem with the oral drug is that bioavailability is highly variable. What you need to know is metabolism of busulfan happens in the liver with conjugation with glutathione, and the clearance is age dependent. So what happens is usually we see that less than 6 months there is a decreased clearance, and there is a higher clearance in ages of 1 to 4. So it is always important that we do pharmacokinetic monitoring of these patients, because we need to see that we are giving them the right dose and not underdosing them or overdosing them. So you should know that it is important that regardless of age, doses should be based on PK monitoring. So usually in our unit we follow PK monitoring and the curve we around to micro to disease the bio is high variable, and the size of the tablet makes it difficult for our children patients to take, and because redosing after vomiting can cause increased toxicity, so we use usually now the IV formulation which can be given once a day, and single daily dose we give, and avoids variable bioavailability because of its better predictable pharmacokinetics and improved safety profile. So what you need to know is busulfan is a very lipophilic agent. So it actually crosses the blood-brain barrier and has the propensity to cause seizures. So we always use anti-epileptic prophylaxis. Some units use clobazam, some units use Levipil, I have seen some European units using phenytoin also, but you always have to use an anti-epileptic prophylaxis for all patients on whom you're giving busulfan. Usually we start on one day before and we end one day after we finish the busulfan. And as per the toxicities, you know that it's common to get nausea, vomiting, diarrhea, and mucositis, a lot of mucositis with busulfan, pigmentation changes, seizures, like we told, and VOD. VOD is a very, very important side effect which can come with busulfan overdosing or due to the patient characteristics also. And you know that we have discussed that busulfan can also be a pulmonary toxic agent, and late effects always exist for all of these patients.
Okay. As we got to know that a busulfan has a hepatotoxicity and the VOD symptoms, to monitor those, as a nurse, we have to do the intake output chart to monitor the volume of the patient in a body, and abdominal gut to notice the ascites over accumulation of fluid, and a daily weight of the patient to monitor the weight.
Yeah, so we have to pick up these things fast in a patient in whom we are giving busulfan, because you know this can lead to very life-threatening situation also, along with our platelet refractoriness. So it is important.
As we also monitor the high flow oxygen in the by giving busulfan to notice the pulmonary toxicity.
So high flow oxygen we avoid usually because it can add to the toxicity. So coming to triosulfan, it has the same immunosuppressive properties, but the comparison to busulfan, it's that the less risk of VOD and less risk of CNS manifestations. But we do practice in a unit less than 1 year of age. We give this anti-seizure prophylaxis in a similar manner. And what is very interesting is triosulfan we can give based on body surface area sense. The PK becomes that the pharmacokinetics becomes less vital for these cases. So we use once a day for the 3 days IV dose. So based on the body surface area that is less than 0.4, we use 10 gram per meter square per day. 0.4 to 0.9, we use 12 gram per meter square per day, and more than equal to 0.9, we use 14 gram per meter square per day. And it is less toxic and does not undergo hepatic metabolism. Coming about melphalan Melphalan is again a nitrogen mustard, and the dose we use is 140 to 200 mg per meter square. Anything up 140, like we discussed, is myeloablative. Less that, we call it RIC. So less than equal to call it RIC. And then you need to know that its half-life is very small, that is 30 to 60 minutes, and causes a lot of side effects, right? So main important thing you have to know is hematological, definitely suppression is there, and gastrointestinal side effects, that is mucositis, is very important. And high dose mel can also cause lethal cardiac toxicity. And you need to know that it's also nephrotoxic, that is, it can cause renal tubular injury.
Yeah, melphalan has an highly nausea feeling and the vomiting sensation. For that, we'll give high emetogenic drugs, and it also has a mucositis. For mucositis, we'll give cryotherapy by using flavor ice cubes. We'll give hydration to the patient, and we'll watch urine output carefully. And it is a nephrotoxic drug.
So this is very important, that you need to know that melphalan is given over a short infusion over 15 to 30 minutes, and that during this infusion you have to monitor all the vitals and the intake output, of course, with the hydration. But the main important thing is the cryotherapy, you need not forget. So we give a lot of ice cubes or ice cream for the oral cryotherapy because of the mucosal side effects of the melphalan. So coming to an important drug, which is cyclophosphamide. Cyclophosphamide again is a alkylating agent, where it is a dose dependent manner. It does the B cell and T cell ablation, and you know that in a low dose it even causes B cell tolerance, and function of regulatory T cells is also affected. But in high doses it causes a very profound lymphocyte depletion and has little effect on the stem cells. So this is what we actually generally use when we use it for PTCY. So the dose usually in the conditioning part is actually 50 to 60 mg per kg per day, and administered typically over 2 to 4 days. Now, as you know, that cyclophosphamide is actually a pro-drug, and it is converted to active and inactive metabolites. And what you need to know, what is important, is that it has a very toxic metabolite called acrolein, which causes a lot of issues, where it is going to be our hemorrhagic cystitis. So you need to watch out for the definitely the mucositis and GI disturbances, but hemorrhagic cystitis is important. Cardiotoxicity is another very important manifestation, because it can lead to ECG changes like tachyarrhythmias, and it can even cause direct side effect on the heart. That is also carries the VOD.
That we are giving has antiemetics like pre-medications along with cyclophosphamide and mesna. After 24 hours the infusion, we'll give to the patient, and we'll monitor it. For that, do ECG and echo. Less than 2 years, we'll watch for SIADH.
So what you need to
है
know
सब
is
क्या
what is
किया
mesna. So usually our unit we follow. Sorry, can someone mute themselves? Yeah, so thank you. So basically, what you need to know is that important is MESNA, and in our unit we follow 1.8 times. Some unit follow 1.6 times. Unit follow 1:1 or 1.2 times, but we follow 1.8 times. And we have seen that MESNA infusion helps. That is a continuous infusion in this cyclophosphamide patients.
As NAC in time saves lives, as we use in Little Star Hospital 100 to 150 mg per kg per day continuously IV infusion.
So, Mucinex is a wonderful drug, that is mucomix of mucinex, that is N-acetylcysteine, because of its antioxidant and anti-inflammatory properties. And also it helps in glutathione synthesis, so helps in actually reducing a lot of side effects, especially the hepatic side effects, and also the side effects with cyclophosphamide. So we are actually continuously using to avoid mucositis in our patients, continuous infusion of N-acetylcysteine. Usually, actually, what we are practicing is in the day minus days, we are practicing an oral formulation either in the tablet form, or if the patient is too small, then we are giving it an IV formulation itself. But post transplant after day zero, we are following an continuous IV infusion. So coming to the next drug, which is thiotepa. Thiotepa is again an alkylating agent. The dose is 5 to 15 mg per kg per day in 1 to 3 days. And as you know, we have discussed that more than 10 causes fully myeloablative thing. And it is again lipid soluble and can penetrate blood-brain barrier. And you will see the toxicities related. The most important one, which I can tell you, is the very horrible skin rash and the thiotypa rash which we get, and it is mostly due to the excretion or secretion into the skin when we are giving thiotypa, and it causes a lot of toxicity there. And definitely the CNS toxicity and hepatic toxicity has to be highlighted, and also long-term side effect of secondary leukemia.
Yeah, Thiotypa has an discoloration of skin and extreme rashes like erythematous patches in inguinal area and genital area, neck and axilla, erosion in inguinal area and buttocks, perineal exoceration. For that, we are going to do sponge bath 4 times in a day. Sitz bath 3 times in a day, along with a line dressing.
Also, we don't keep the same dressing, tegaderm or the basically the film which we use. So we are actually changing that also as a part of the skincare during thiotypa. So coming to the anti-metabolite agents, so we have the fludarabine, which is a purine nucleoside analog, and the incorporation to the DNA as a false nucleotide causes early DNA chain termination, and that is the way it acts. And the immunosuppressive properties are the important ones, and that is why it is very evidently used in the PTIS protocols for the hemoglobinopathies which we follow. Typical dose is around 30 to 40 mg per meter square day for 4 to 5 days. So total we target something, let's say, between 140 to 200. And obviously the toxicity has to be very importantly the myelo and the immunosuppression, but at the same time you should not forget about the neurotoxicity. So it is being increasingly used in all the RIC formulations, RIC conditioning regimens.
Fludarabine has a side effect.
We give irradiated blood products only, and generally is what we follow at our unit, and most of the patients do end up getting only irradiated blood products when they give fludarabine. So coming to carboplatin is a platinum compound and binds to purine bases in DNA, causing cross-links and DNA breaks. Is that how it acts? And it's a very myelosuppressive when compared to other platinum drugs, hence increasingly used in conditioning regimens. So we have used it in mostly in rhabdoid tumors and germ cell tumors, autologous transplant. And as the side effects with the platinum compounds, the ototoxicity, renotoxicity, and neuropathy is important.
So carboplatin will give a hydration, RFT monitoring to renal toxicity and magnesium levels too due to the hypomagnesemia.
Yeah, so there is renal tubular injury that so many of the patients have a prolonged hypomagnesemia, even sometimes refractory post high dose carboplatin when we give for autologous. So we have to keep that in mind. So another agent which we are using is etoposide, which is actually a topoisomerase 2 inhibitor. It's cell cycle specific, used increasingly in autologous, but also we have used in full match allogenic HSCT when instead of Cy-TBI, some people use etoposide TBI, which is 60 mg per kg high dose. And as you know, the side effects being mucositis, hypotension, and palmar-plantar rash. So what we need to take caution during etoposide dilution.
During etoposide dilution, as in us, we have to take care of the fluid used in dose mg per 0.4 due to the precipitation.
So, as you know, that etoposide has a high risk of precipitation. So, and that causes a lot of problems during the conditioning also. So, what we usually do is we dilute it with a higher amount of fluid, like as you all know. So, yeah. So, if suppose 100 mg of we are using, so 50 ml we will use the fluid.
ಏನ್ ಲೀಕ್ ಆಗತ್ರಿ ಹೋಗಿ ನೋಡ್ರಿ ಸರ್.
Can,
Can I please request others to
can we
mute
mute
themselves?
the
Thank you.
EG
Yeah.
and the ETA? Yeah. So, thank you, ma'am. So, coming to the installations with the ATG and the ATLGs. So basically, we use this increasing using the ATG and the ATG even on the other towards the donor, when we decide to use ATG, we always see what dose we want to decide, what source is it, horse or rabbit, or we are, what is the HLA disparity, what is the graft source we are using, what intensity conditioning we are giving. So when we have seen ATG, ATLG is being used increasingly to prevent the GVHD after allogenic HSCT, and even for HLA identical sibling donors also we are using increasingly now. All right. Coming to the doses, when we use ATLG, that is the product called Grafalon, we are using total cumulative dose about 15 to 60 mg per kg in 2 to 3 days, and sometimes 4 days also we give. And then the AT is either 1.5 mg per kg per day for 3 days to 2.5 mg per kg per day for 3 days. And as you know, there are a lot of side effects, especially look for viral reactivation. Alemtuzumab is one wonderful drug which is not very readily available with us, but it is an excellent drug for in vivo T cell depletion, and it has shown a very good experience in mud patients when we use alemtuzumab, which is Campath. So what precautions do we take for ATG?
For ATG, we'll check for the horse and rabbit and we'll give pre-medications checking time in every daytime. If we have symptoms like fever, disproportionate tachycardia, allergies and anaphylaxis, hypertension, hypoxia. ATG protocol test dose has to be done before giving ATG, and pre-medication has to be given, and 0.2 micron filters has to be used before administration, and slow infusion to be given to 8 to 12 hours.
So we have to follow always the 0.2 micron filter when we give ATG, ATLG products, and important is to know that it can cause a lot of side effects and reactions. So always start it during the daytime. Don't keep it for the night time. Start it early with a test dose and increase slowly, and look for any side effects or reactions in the patient. So coming to the B cell agents, rituximab, very interestingly, I wanted to talk about this in the conditioning because most of us don't utilize this in the conditioning, but there are a lot of papers where they have used it in the ABO incompatible grafts, very, very highly incompatible in high risk patients. They have used rituximab, and also added advantage, it prevents PTLD. But what in my clinical experience, where I have used it more commonly is when we use this TCR alpha beta depletion in the haploidentical cohort. When we are doing the TCR alpha beta depletions on day -1, it is helping in the B cell depletion, and helping us more than
So we can't hear you clearly.
also. So
Wahid,
we
you were
use typically
interrupted
the
for a
early
moment.
Hello,
Yeah, you were
is
interrupted
it
for a
okay now?
moment. Yes, yes.
Yeah. So shall I repeat
Periodically, it's
this one?
getting interrupted. Yes, yes, please, please.
Yeah. Okay. So yeah, please go ahead.
Rituximab protocol, slow initiate of infusion rate and slow initiating of infusion rate and then increase gradually. Pre-medication administration rituximab before rituximab is very much important, and slow infusion of rituximab is to be taking place.
Okay, so
What are the
that was about the basic radiation and the chemotherapy, and now we will talk about the general things which we do during the conditioning, and little bit, it overlaps with what we do after the after the transplant also. So what you need to know about this is basically the sources of infection which can happen during your period of conditioning or post conditioning. That you should know that the most of the patients or children are at risk of infection from their own body bacteria, which resides in the mouth, skin, gut, urinary tract. And also on the added thing, we have the central venous access device, which can be a source of infection. So now my staff nurse Mamta will tell us about the routine care of the child in BMT, including the various components and what agenda, under what heading she will cover it.
In a patient. Those includes CVC care, safe environment, mouth care, respiratory hygiene, skin care, perineal hygiene, clean diet, and febrile neutropenia. Challenges all through the BMT. So, coming to the CVC importance which we need to notice, like difficult peripheral line access. we have to access the line very properly. All the patient have the tunneled catheters like Hickman catheters or peripheral inserted catheters, central catheters, and HT shoes. We are using the Hickman line catheters, and in every patient, 10% patient has a chance of CLEPSY, that is central line associated bloodstream infections. Performing a sterile dressing changes if found solid wet or if dried blood notice at the site is very much important. Change the dressing immediately, and dressing has to be done in every 7 days. Appropriate hand hygiene is much important during administration of the drug and during when we are touching during the central line. Flushing the of lumen with Heplox and saline is to be done carefully. It is most important during CVC care. CVC care. How we are going to manage? Scrub the hub with alcohol slab thoroughly for 30 seconds and let it dry. Use needle for infection free, which when patient have disappropriate tachycardia, chill fevers, any redness or swelling near line site, should inform a doctor immediately, consultant doctor and DMOs immediately. Will need to remove the CVC in emergency purposes like fevers, tachycardia, chills, etc. So in BMT unit, we need a safe environment. That is like HEPA filters room with 1:1 nursing allocation for each patient. Avoid contact with people with infections. That's why you use HEPA filters rooms. Avoid building woodwork. When patients are admitted to avoid the fungal spores. No flowers or solid related items, stuffed toys, woolen blankets, woolen wear to be nearer to the patient to avoid the dust and fungal spores. Coming to the mouth care, mouth care is must ensure during BMT. It is a care which is very important. Oral hygiene is an integral part of total care. To avoid the mucositis, will keep mouth cleaning and make it moist for infection free. We have to clean the mouth with chlorhexidine. Care of mucositis with the pain relief like mouth pain, locks, and easy tricks. Respiratory hygiene. For respiratory hygiene in BMT, we'll go with the 3 times chest physiotherapy and intensive spirometry above 3 years of the child. Skincare. Skincare ensure skin is well moistured, has dry skin, can cause skin cuts. Cleaning skin is very much important. Has a microorganism on body skin, can cause severe infection in neutropenias. Antiseptic wipes to be used during skincare in entire body. Perineal hygiene. After every defecation, wash thoroughly with soap and water, hand wash and sitz bath. We need to use tip bag for local applications. Cleaning diet. Cleaning diet. Hand wash must be done. Mostly we'll use neutropenic diet. For all food must be well cooked and avoid raw cooked, and it should be rawness. Only as consume pasteurized dairy products and mineral boiled water. Con- uh, Always use sanitized utensils and clean containers. Febrile neutropenia. Rule of thumb. Febrile neutropenia. First initiate impression. First, in febrile neutropenia, the neutropenia neutrophils are below 500. Initial impression is first minute. First, assisting the patient is very much important. During assessment, it should be in 1 minute. And second thing is primary assessment and collecting investigation. It should be done in 10 minutes. The time is taken is 30 minutes. Before 30 minutes only, we have to give the first dose of antibiotic, that is in 20 minutes, which is the febrile neutropenia protocol. Supportive treatment. Example, compensated shock treatment to be instituted immediately. Call for the help. Inform your consultant every fever spike. Mon- so here we have to monitor the vital chart and monitor the temperature chart. Blood transfusion. ABO incompatible stem cell transplant can lead to the blood group changes. So we have a blood group changes. So during the blood transfusion, we have to monitor the blood group and recheck and cross check with the blood group and bag number and the name of the patient which we got the blood. Double check, double check the blood group with physician team and record before transfusion. And my vital should be checked before and after the transfusion. Always irradiate the products except frozen FFP, except SFP and cryoprecipitate stem cells. Challenges all through the BMT are Fred and sick due to the chemotherapy, diurnal weight according number of medication. Challenges all through the BMT. Language barriers during patient. We have to be a we have to be appropriate language should be spoken with us. Isolated sickness. If the patient is isolated sickness, we have to be more attentive and we have to concentrate on psychological status of the patient and divert the mind of the child, like providing the mental activities like colors, paints, maths, worksheets, grammar tests, etc. We have to be more loving and care empathized.
So that was about the general things which we do for the BMT during the routine throughout the admission. We have to be very much aware about the patient's psychosocial issues, age-related issues. Like, a 5-year wouldn't be that bothered by a BMT unit rather than when you compare it with a 18-year-old. 18-year-old would probably be more bothered. So you have to see the age appropriation. Psychosocial support should be given to them. Psychological support, social support, give them activities, make them busy, keep them active, and always try to keep them engaged so that they are enjoying their stay rather than just being stuck in something like in a box where the treatment becomes too boring for them, or too occupying them. So always me personally, I involve the patients in activities. I make them go on walking, so that is, so the active they are, the better they are, they get out fast. So our key points in this entire talk was basically the conditioning measurements integral to the HSCT treatment. And we have now started using increasingly the reduced intensity regimens where we are using for frail patients or the patients who are having poor performance status, or for the non-malignant transplants we are using more. And what is most important is the last sentence, that is the role of nursing is the key for a smooth conditioning period, and this will transfer to a smooth post-transplant period, because the conditioning period is mostly the period where nothing much goes wrong and you're in the quiescent phase. All the rocky road starts after the transplant. So if you have a very good fertile soil laid during the conditioning period, you'll have a very good post transplant period as well, and that is a very important role for the nursing. So, thank you everyone. Thank you, Dr. Dharni ma'am. Thank you, IPPHO chapter. And I would like to thank even Dr. Ramana Dandamuri, my senior consultant. He has guided me through this presentation also. And this is our team at Little Stars, and this is the our first thalassemia patient who underwent full match transplant. She has completed 1 year post transplant successfully with a very good chimerism, and this was the photo which we took at that time. So yeah, thank you so much. Any questions?
Thank you so much. Thank you so much, Wahid and Mamta. So that was really wonderful. You have completely covered everything. Not only covered everything, you have, the hard work that you have both have put in is really visible. That you have, systematically arranged the topics and got it in steps, and you have combined it together in such a way that the doctors and nurses' perspective are brought out together.
Thank you, ma'am. Thank you.
Sincere appreciations for their efforts and
Thank
your
you,
team
ma'am.
as well. Thank you so much. So, any questions for the speakers from the audience? So, yeah, Neeta ma'am or her team, we don't know. So, she has asked about skincare, Thiotipa and Triosulfan. Please explain once more. Thank you,
Uh,
Neeta ma'am, for joining us. Yes,
Thank you, ma'am.
Wahid.
Thank you so much, ma'am. So, for thiotepa, usually the excretion is in the skin, as we know, and we see a lot of a very bad rash. Actually, it's such a rash. If you get once, like it's a very troublesome, especially for very young children, less than 2 years. So, what we usually practice is a 6 hourly bath. 6 hourly bath, along with complete, the patient's dress will be changed, the patient's bed sheet will be changed, the patient's pillow cover will be changed, the patient's blanket will be changed, and also even the dressing which we do with the tegaderm, that also we change, because we don't want any amount of thiotepa which is excreted or whatever, the side effect rash which comes to stay onto the skin. So this is what we are following very strictly. So 6 hourly bath and wipes anyway we are doing. So that we follow on the day of thiotepa and the next day also. So for 2 days when we give the thiotepa. So thiotepa usually we give in two divided doses. So on the day of thiotepa and the one day after thiotepa, we follow this skincare.
Thank you, Wahid.
Thank you, ma'am.
Any
Any
other
other questions?
question? So, I don't see any questions further in the chat as well. If there is none, then thank you so much, Wahid and
Thank you, ma'am. Thank you
Mamta
so much
once
for the
again.
opportunity.
Thank you so
Thank
much.
you, ma'am.
Thank you.
Thank you, ma'am.
Thank you. So we'll
Thank
close the
you.
session. I'll hand over back to Himanshi. Thank you.
Thank you so much. Thank you. I'll end the meeting now. Thanks.
Thank you.